Okay, well, I was doing this last night and did ask myself the question, why did I pick this topic? It's one of those topics that you want to try and make simple. The more you do of it, the more complicated it seems to get. And obviously having a renal physician watching as well just puts pressure on it a little bit more.
Not at all. I'm quite looking forward to this.
We know Christmas has come early. We've got a couple of hours of acid-base physiology to discuss things through. So I'll try and make this as sort of conversational as possible. It does get a bit geeky, I think, unfortunately, which isn't really me. Now, I was told by a lecturer when I was at university that it's much better to be lectured by someone who's not an expert because they go down dark tunnels and go into detail. So I can reassure you, you're in good hands. This is an attempt, but I think I've drifted off the path a bit, to try and have a sort of fairly pragmatic approach because the theory of it all can get quite complicated. So what we'll try and cover, if I can stop spluttering, is some sort of basic concepts and definitions. We all know the kind of bedrock of clinical bedside practice is all to do with just one buffer system, the carbonic acid bicarbonate buffer system. So we're going to have to concentrate on that, but it is very old school, but it is what we use. Then the sort of springboard from that is the primary acid base disturbances. And I'm aware I'm speaking to quite a senior audience, so I hope I don't want to teach, grannies to suck eggs, but we'll just review some of the basics. A little bit of chat about the compensatory mechanisms and how we assess them, because of course, just because we identify one primary process, it doesn't mean that's all that's going on. There could be more than one at any one time, and potentially three in the classical system. We need to understand a little bit about the anion gap, and that should, in my view, be an absolutely standard thing to assess in every blood gas that you look at if you think there's a problem. And analogous to that is the Osmolal Gap, or Osmolal Gap, as I've written it there. I think simply to talk around the limitations of the classical carbonic acid bicarbonate system, I'll just touch on what you've probably heard about, the physicochemical or Stewart's theory, which is not new at all. It's been around for donkey's years, but it isn't very user-friendly. It's not very practical at the bedside. But at the end, what I tried to do is put together a sort of clinical approach. What I wanted to do after that was some clinical vignettes, but I just ran out of time, to be honest, so I don't think we'll get to those. Anyone who wants to ask anything or tell me I'm wrong, just chip in at any moment. So let's just start with a sort of simple concept. I'm going to have to pick on you guys, aren't you, because you're in the room. Emily, what do we mean when we talk about acid-base balance? What on earth are we talking about?
Acid-base balance.
Yeah, what do we mean by that?
We're looking at bicarbonate and hydrogen
yes.
balance, which determines the pH in the body, which means where normal is and what is it acidosis, is it normal, is it alkalosis?
Yeah.
From whatever cause.
Yeah, okay. So we've got this concept of pH, which we'll come to. We're all very familiar with it. Has anyone else got anything to add to that as a concept? What else we're talking about? I think, to be fair, I think you covered it. What we're actually, the other term for it that I prefer is what we're talking about is hydrogen ion homeostasis. We're used to talking about sodium balance, potassium balance, and other electrolytes, but the hydrogen ion is quite unique. What is a hydrogen ion?
Proton.
It is a proton. So a hydrogen ion is, it's not a fundamental particle, but it is a hydrogen atom that's had the electron removed. And protons make up the nucleus of all, contribute to all atoms. So it's a very basic particle, and it's a bit of a mysterious beast. It isn't quite like sodium or potassium. It doesn't really exist on its own. It's very ephemeral, and is nearly always associated in chemical reactions with other bigger molecules or other bigger atoms. One of the striking differences is just what we're dealing with in terms of nanomoles, in terms of concentration. We're nanomoles, not millimoles, so 1,000 times smaller quantities of this particular thing. One we'll look at what we mean by pH in a minute, but what's interesting, when you look at what the human body can tolerate, and people usually quote a pH between 7.8 and 6.8, you see a tenfold change in hydrogen ion concentration across that range. Can you think of any other blood element that can change tenfold? Imagine if your potassium changed tenfold or your sodium changed tenfold. It would have a huge impact. But within physiological range, so pH is between 7.36 to 7.44, there's minute, fine control over the concentration. There's quite a high turnover, but in reality, we don't lose or gain much in the way of hydrogen ions. Most of it runs through aerobic metabolism, and as a result of ATP hydrolysis. And don't forget, water itself can hydrolyze into hydroxyl ions and hydrogen ions. So water plays a big part in this, as does CO2, which we'll come to. But most of our body's hydrogen ions are recycled through aerobic metabolism within cells. But quite a lot of it, when you think about how much there actually is in the body. So pH then, so mathematically, pH, as we know, is the inverse log to the base 10 of the hydrogen ion concentration. And I don't honestly know why we don't talk about nanomoles. It just makes a lot more sense. But what's striking about that relationship is the amount of change in concentration of hydrogen ions from I don't think I need to see anyone with an alkalosis of 7, or alkalemia, I should say, of 7.8. But there you'd have a hydrogen concentration of 60, normal being 40. And then some of the DKAs we come in and see, in theory, have hydrogen ion concentrations of 160. So this huge tenfold change in hydrogen ion concentration. It's also not quantitative, so pH can give us a distorted view. So you can see that a pH change of 7.4 to 7.3 is only a 10 nanomolar change, whereas 7.1 to 7, still one pH unit, is twice that, it's 20 nanomoles. So you need to be aware that the change is well, it's logarithmic, it's not linear. So it can deceive us slightly, but it is impressive what range of hydrogen ion concentration we can actually tolerate. I'll come back to that in a second, what's the relevance then of pH biologically? Why do we want to control it so closely? Anyone got any thoughts? Say again? Yeah, so enzyme systems. Just about anything you mentioned metabolically. If you think of biochemistry, it's all in solution. I'm going to start talking about acids, weak acids, strong acids, and pH will affect dramatically the associated and dissociated elements of these molecules. But also the ionization of drugs, of receptors, of ligands. It's hugely important, as you said, the way enzymes work, their rate of reaction, the way membranes work. It's absolutely fundamental to biochemistry is the answer. So, just very quickly, going to go around the room again. I'll leave Alex out of this. Very simple sort of O-level chemistry stuff here. What do we mean by acid? What is an acid?
Proton donor.
Yeah, proton donor, a base, proton acceptor. What's the difference between a strong and a weak acid, and what do we have most in our bodies?
Strong acid completely dissociates.
Yeah, yeah. So an example of that would be something obvious like hydrochloric acid in water that will almost entirely exist as hydrogen ions and chloride ions, as opposed to a weak acid. Carbonic acid would be the obvious example in this talk, which is very pH dependent on its degree of association or dissociation. And it's a really fundamental concept to understand, and we're going to come to it in a minute, the Henson-Hasselbalch equation of why weak acids can act as buffers. And at the bottom we've got buffer, so a buffer is the combination of a weak acid and its conjugate base that will resist pH change if you remove acid or add base. And this is the fundamental way in which we control biological pH. Any idea what I've picked this has come out of textbooks, obviously. People talk about volatile and non-volatile acids. I don't find this terribly helpful, but Do you know what's being referred to there? Anyone at Glenfield, feel to shout out if you. Classically, when people talk about the volatile and non-volatiles, this is around the carbonic acid system. And the two organs that we think of are the lungs and the kidneys in controlling acid base. And volatile acid is really carbonic acid and the fact that CO2 has such a close link to the level of carbonic acid and then its dissociated parts in our bodies. So that's volatile acids. The non-volatile acids can be thought of as either organic or inorganic. And the organic ones are the anion gap type things we think about, so ketone bodies and lactate. The inorganic things are things like phosphates and sulfates and other unmeasured weak acids that we just don't think about in everyday practice very much. So having a vague understanding of the different definitions, I think, is quite useful. This is more exam stuff now. So the difference between, this is sort of peccadillo, between acidosis and acidemia. What's an acidemia? Yeah, it's an abnormally low pH. So acidemia is a state of lowered pH. The acidosis is the process, likewise for alkalosis and alkalemia. The real peccadillo is hypoxia and hypoxemia. So hypoxemia is a reduced PO2. Hypoxia is a process that can be caused by many things. So when you look at the blood gas, if the pH is below 7.36, you'd say there's an acidemia. If it's above 7.44, you'd say there's an alkalosis. Base deficit or excess? What's a base deficit or excess? The first thing to say is they are calculated entities. It's a calculated parameter. What does it actually represent on the blood gas that says patient's got a base deficit of -7?
I guess it reflects the amount of, is it bicarb that you need to add to normalize the pH?
Yeah, essentially. Yeah, so both standard bicarbonate and base deficit excess represent the metabolic components of any derangements. I don't really look at standard bicarbonate very much. Base deficit, if you've got a blood gas that says the base deficit is -10, for that patient, for every litre of their extracellular fluid, you'd have to add 10 millimoles of bicarb in the presence of a normal PCO2 and normal temperature to get the pH back to 7.4. If it's an excess, you'd have to take it away. So it's simply representing the metabolic components. The standard bicarbonate is the corrected bicarbonate for PCO2 of 5.3 and the normal temperature, so it's a similar thing. If you look at the standard bicarbonate and the actual measured bicarbonate, that should roughly equate to the base deficit, is my understanding. Unless Ricky wants to correct me there. Would you agree, Ricky? He's gone.
No, that sounds good to me, yeah.
Just checking you're still there, Ricky.
I'm still there, don't worry.
So we've talked about, this is the fundamental bit of buffers, and a tiny bit of chemistry, and I'm no chemist. We've talked about the impact of buffers, and particularly the carbonic acid bicarbonate buffer, and the way they work is based around the Henderson-Hasselbalch equation. And I'm sure you remember it, but there's I've used equals there because I couldn't be bothered to find the little thingies for the arrows. I couldn't find them on my computer. But the CO2 and water can combine to form carbonic acid, and that can dissociate into hydrogen ions, bicarbonate ions. And we can see how the kidneys can be involved in one end with either reabsorption of bicarb or excretion of hydrogen ions, and we can control our PaCO2 through our alveolar ventilation on the other. So the kidney and the lung in this system marrying quite nicely, and I think it's partly why it's become an attractive model to think about acid base. And we use this as the principal determinant of our acid base analysis. But it's the Henderson-Hasselbalch equation that really explains what's going on. And the Henderson-Hasselbalch says that for any weak acid, there is a dissociation constant, and the dissociation constant represents the degree of dissociation at any given pH. We're using inverse log here, so we use the inverse log of the dissociation constant. But the pH is given by the inverse log of the dissociation constant and log to the base 10 of the acid, of the conjugate base over the acid. And that will apply for any weak acid. So if we plug in the numbers for the carbonic acid system, using bicarbonate and carbonic acid. The pKa for that is 6.1, and if memory serves me right, the pKa is also the pH at which that acid base will be 50% dissociated and 50% associated. That's where the model comes from. So if you plug in the numbers, you can convert carbonic acid to CO2, they're proportionally linked, and the 0.225 is the that's what I'm looking for. The dissolving factor. That's not quite the right word, is it? The you know what I'm trying to say. It's the absorption coefficient of CO2 into water. And what you find is if you plug the numbers in with the PCO2 of 5.3, a bicarbonate of 24, and with a known pKa, you get a pH of 6.4. If you change the pH, you can see how that system moves, and the amount of conjugate base and acid will move proportionately. At pH 7.4 then, with a pK of 6.1, what rough ratio would you expect carbonic acid? Do you think it's going to be mainly in its conjugate base form, or maybe dissociated? Which way around is it going to be? I'll guess. I kind of said all that. So plasma pH, two main controlling factors: renal excretion of hydrogen ions and regeneration or reabsorption of bicarbonates, and alveolar-minute ventilation for PCO2. We'll come back to why we know this is a simplified model. We'll come back to that in a second. This is sort of schematic of what I've just said. But given that pH, you've got associated to disassociated about 20 to 1 at that pH. And obviously it shifts depending as pH changes. Just going back, if I may. I think that's a useful diagram. I'm going to come on to talk about, so the Davenport diagram, hopefully familiar to you. I think it's quite useful in reminding yourself what happens during compensation. So let's look at probably the most common primary acid-base abnormality we see in ICU, a metabolic acidosis. So here's the pH of 7.4, bicarbonate of 25-ish. So to the right, we've got alkalemia. To the left, we've got acidemia and the processes of alkalosis and acidosis. So in a pure metabolic acidosis, we obviously see the pH drop and we see the bicarbonate drop. And these lines on the Davenport diagram demonstrate all other things being equal. And this is the problem with lots of other things that may not be equal. You travel in this direction. So the compensation for a metabolic acidosis will be a what? Yeah, a respiratory compensation or respiratory alkalosis. So you hyperventilate and you drop your bicarbonate further in this direction to try and get back to a pH of 7.4, which you never actually get back to. Similarly, for, pick another one, respiratory acidosis, you'll travel along this line as your CO2 goes up, your pH drops, your bicarbonate goes up a little bit, and you'll compensate over time with increased bicarbonate from the kidneys, and you get renal compensation traveling this way. I think it is a useful schematic to have in your head, the Davenport diagram. We don't tend to look at it much anymore. But it is simplified, and it's based on a lot of assumptions. And these are some of the assumptions, because we're just thinking about one buffering system within our physiology, and of course that's deeply unrealistic. Most of the carbonic acid bicarbonate system takes place in the red blood cells, and it is a potent sort of effect, but a huge other effects are other buffering systems, plasma proteins in particular, and that's why your albumin and your total protein can have an effect on acid base. You've got the other inorganic systems like phosphate and sulfate, and hemoglobin itself can have a buffering effect. Let's get rid of that. And this is one of the issues we'll come back to when we talk about the Stewart hypothesis, why the system is oversimplified and why some acid-base disturbances we see clinically aren't easily explained by the carbonic acid system. So that's just a nice simple schematic of the main four primary disorders we tend to think of using the carbonic acid system. So metabolic acidosis, a metabolic alkalosis, a respiratory acidosis, and a respiratory alkalosis, with those primary changes of bicarbonate and CO2. And then, as I showed you in the Davenport diagram, the simple compensatory changes. The problem we've got is that we may have more than one process going on. And one of the things I think you have to do to some degree, and I don't do it quantitatively, I like to think I do it qualitatively, is when you look at a blood gas, is to assess, is the compensation you're looking at, so let's say it is a nice run-of-the-mill metabolic acidosis, the bicarbonate's dropped, the patient hyperventilates, the CO2's come down, the bicarbonate's dropped a bit further. Is that an appropriate compensation that you can happily say this is a metabolic acidosis with a respiratory alkalosis as compensation? Are people vaguely familiar with, they're not very user-friendly, but with the rules that we can use, the compensation rules to assess at the bedside? Here are the Boston rules. I don't think many people use them, as I said, quantitatively at the bedside. But the concept is to determine the primary process, look at the pH. Is it an acidemia? Is it an alkalemia? Then by looking at, really going to look at the pH, the PCO2, the bicarbonate, and at least the base deficit, decide what the primary process is causing that acidemia. So what's the cause of the acidosis, respiratory or metabolic? Then have a look to see what the compensatory mechanism is. If the expected alteration through compensation meets the actual numbers you see, you've got a straightforward compensated state. If they don't, then you might have a mixed disorder, and you've got to consider that. So you might have someone with metabolic ketoacidosis who's also got acute respiratory embarrassment, they've dropped their GCS, someone in ED is giving them 20 milligrams of morphine, and they're hypoventilating. So you've got to be able to distinguish between a simple compensated setup and a more complicated setup. I'm not going to linger. So these are the 6 rules that I remember and was always taught, and you can kind of read them. But the concept is, and this is on data from 20, 30 years ago. I think it was human data, but it's ballpark figures. So just for an example, if someone comes in with an acute respiratory acidosis, they've got a raised CO2. Let's say they're obtunded from taking narcotics, and you look at their blood gas, and you're looking at the bicarbonate, you can work out if the change in the bicarbonates, the metabolic compensation is appropriate. And the rough rule of thumb is that for each, the bicarbonate should go up by 1 millimole for each 1.32 kilopascals of elevation in CO2 above 5.3. And you can plug that into the equation. And this is a fairly fast compensation process. So that was a acute respiratory acidosis. For a chronic respiratory acidosis, as you'd expect, that number changes. You get a bigger compensation. So rather than 1 millimole per 1.32, it goes up to 4 millimoles. This will take longer to compensate. In acute respiratory alkalosis, if someone hyperventilating for some reason, you should see a 2 millimole change for bicarb, a decrease this time, not an increase, for each 1.32 change in kilopascals. There's a limit to that level of compensation in respiratory alkalosis. That's the equation for chronic respiratory alkalosis, relatively unusual scenario. Metabolic acidosis, you're looking at changes in PCO2. So the expected PCO2 should be roughly a fifth of the bicarbonate plus 1. And again, this is something that might happen over hours. And again, there's limits. There are some amazing gases. I remember being in a lecture at, I think it was one of the intensive care society meetings in London, where they take gases on people on Mount Everest, compensating for hypoxemia with CO2s, and they were getting their CO2s, thick mountaineers, down below 1 kilopascal actually, and were also then developing severe respiratory alkalosis. But most people are going to be limited to getting their CO2s, not much below 1.5. And then the final one is for metabosis. So it's worth being aware of those. I'm not suggesting at the bedside you're going to take your calculator out, but just have a look at the compensation and eyeball it. And when you get used to doing it, you'll get a feeling for whether there's more than one process going on. Obviously, the clinical picture is going to give you information about the likelihood of two processes, but just bear those compensatory rules in mind. Any questions on those? Anyone actually use them in practice? Alex is shaking his head.
I'll jump in. Yeah, so I do use them in practice. I use rule 5, I think it was. I think that's that Winter's formula.
Winter's formula, yeah.
Yeah.
And that's probably one of the most important ones, isn't it?
Yeah, the rest, I must admit, I've seen them, but I've never really, I think I might have written it down on my phone somewhere, but I never really used them. But this one, the Winter's formula, the metabolic acidosis, I find I use that quite a lot, actually.
Yeah, and I mean, a DKA would be the classic example of whether someone's properly compensating. And the DKA is the one that, you know, when you get called to ED, the patient's gasping for breath, and the ED physician wants you to intubate them. This is where you'd certainly have two processes going on if you did that. You'd have a metabolic acidosis and a respiratory acidosis, and they'd probably die. But yeah, I think you're right, Ricky. It's the one that is probably most applicable at the bedside. I think they're a guide, I said, probably more qualitative than quantitative, but not difficult if you've got them written down on a piece of paper, just to check a gas if you think the numbers look a bit peculiar. Okay, so what we've done so far is really looked at our acid base based on the carbonic acid system. We've talked about identifying the change in pH, then identifying the process, whether it's metabolic or respiratory. We're understanding the concepts of the secondary compensatory mechanisms, but the possibility of two primary mechanisms going on. I think before we can draw a line under interpreting the blood gas, at every blood gas, I think you need to have a look at the anion gap. So what is the anion gap? Not necessarily the equation at the moment, but in principle, what's the concept of the anion gap? There's a gap in anions. So where are they? What are they? It's the unmeasured anions, isn't it? We've already agreed there's far more elements contributing to actual plasma pH than simply CO2, carbonic acid, bicarbonate, and hydrogen ions, and the effect of the lungs and the kidneys on those. So there are other things we know we don't measure, and we've talked about some of them. So it's unmeasured cations from other weak acids that we're not thinking about on a daily basis. So it estimates the unmeasured anions. People tend to talk about either endogenous or exogenous. So under normal state of play, when we do the traditional anion equation down here, and you can add things to this, you can add on magnesium, you can add on calcium, and to try and get it more realistic, there is a normal value for those cations that we're not taking into account. And the normal gap is roughly probably around 12. It depends on your blood gas machine. Of course, in reality, there has to be electroneutrality. You can't be, we're not all more negatively or more positively charged, although some people appear to be so in day-to-day life. But you have to be electroneutral. So it's just things we're not measuring. There isn't a real excess of cations. And working out the anion gap is a way of assessing that gap. If it's over the normal value for your machine, you've got to at least consider the possible causes of anion gap acidosis. So dead easy question then to the gang. What about causes of exogenous? What are the common causes of, endogenous anion gap metabolic acidosis? Mentioned one about 1 million times already. Yeah, so ketone bodies, so the oxidative products, beta oxidation of fatty acids, yeah. Lactate, yeah. Those two are probably the commonest, aren't they? Can you think that there's one other that Dr. Bell will be more used to seeing? What's the other very common one? Uremia, yeah. And then exogenous, we're talking about other exogenous drugs, chemicals, what sort of things?
Methanol.
Yeah, so methanol, ethanol, they're interesting ones. Any others? Salicylic acid, really important one. What have I said here? So in a normal anion gap bicarbonate, this is sort of getting a bit more. So in a normal anion gap acidosis, you're losing bicarbonate and replacing it with chloride essentially. Whereas in an increased anion gap, there's another acid, weak acid, that's buffering your bicarb that you're not measuring, you're not seeing. So here's the sort of breakdown: higher anion gap, endogenous, exogenous, DKA and lactic acidosis represent a significant number, but don't forget starvation, so ketoacidosis from starvation and hepatic failure, and then uremia would be the other common one that we see, and the multitude of exogenous drugs or substances people might take. But on normal anion gap, I break down into bicarbonate loss or addition of some sort of acid with chloride, because if you've got lots of extra chloride, you'll see you'll see the anion gap. So gut being a big loser of bicarb, and the things like renal tuber acidosis and some diuretics can have the same effect. So I think it's quite useful to think of it: anion gap, normal or not, endogenous, exogenous, a little list in your head of the different types of things that can cause it. There's another concept which is analogous to the osmolar gap, and that is simply unmeasured osmoles. So it's comparing the either measured osmol through the lab or calculated at the bedside, the 2 times sodium plus urea plus glucose. If there's a big gap, there's obviously an osmoles. If it's ethanol, methanol, ethylene glycol, there'll be an acidemia. It'll be an acidemia with an increased anion gap. If you're not acidemic and you've got a big osmolar gap, just think of these other things that can cause things like pseudohyponatremia. So very off the scale hypoglycemias, hyperlipidemias, and paraproteinemias. If someone arrives with an unexplained hyponatremia and they're sort of euvolemic and you can't work out what's going on and their acid-base balance is normal, it's always worth doing a quick osmolar gap calculation. Are people sort of familiar with doing that? I don't think we get that on the blood gas machines I'm aware of. What we've alluded to all the way, so that sort of covered theory of the carbonic acid bicarbonate system, is that it only covers part of the story. We've talked about other buffering systems that are available to us. It also assumes lots of things like relative euvolemia and normal plasma proteins, normal albumin, and other electrolytes being reasonably normal. And we ignore the role of the other non-bicarbonate buffering systems. And so there are certain scenarios which we can't explain. Hypovolemia, hypervolemia can affect acid base. Water itself can act as a buffer. It dissociates, as we said before, not very strongly, but it dissociates into hydroxyl ions and hydrogen ions. So way back, and I've forgotten how long, someone tried to put a much more comprehensive package together, the so-called Physicochemical Theory, which is really based on the concept of electroneutrality, but looking at all the other buffering systems and the impact of a number of things. One of the things you've probably heard about is the strong ion difference. So the strong ions are the ions that are largely dissociated and spend most of their existence dissociated. Calculating more accurately the strong ion difference has an impact on pH. And I don't really, partly because I don't use it at the bedside and it is complicated. I think you need to be aware of it rather than understanding it. I definitely don't think this is a bedside tool. You can get a Stewart equation calculator online, but I'm not encouraging you to use it. But if you find, so the strong ion difference isn't a million miles away from the anion gap and relates to a number of things, including volemic status. So the strong ion difference is a big component of the Stewart hypothesis, but he also takes into account all the total weak acid concentration, so the plasma proteins in particular. Albumin plays a big part, and he takes CO2 into account, so the carbonic acid systems involved. Again, I might defer to Ricky. I'm not aware of any simple way of using it at the bedside, but I think it's useful just to remind us there's a lot more going on than just the simple elements of the carbonic acid system. It's more theoretical, organic chemistry and inorganic chemistry than a usable bedside tool. Have you got any thoughts, Ricky?
No, I pretty much agree with you actually, Gareth. I sort of tried to get my head around it sort of time and time again.
Yeah.
I've never really found a good use for it at the bedside, really. Some people seem to, say it's fantastic and it explains everything, but I've not really found a good use for it, to be honest.
No. And of course, our blood gas machines are all based around the blood gases system anyway. But be aware, if you've got significant volemic status changes, significant hyperproteinemias, usually albumin for us, or significant changes in major anions and cations in the extracellular fluid, and you've got a strange blood gas, you just might have to think out the box slightly as to what's going on, because they do have an impact. There are loads of quite interesting papers that I started reading and then woke up half an hour later covered in saliva about Stewart hypothesis, and it is quite interesting, but it's not a useful bedside tool. But just be aware of the concept. Yeah, I think I've said that. So I tried then to put together a sort of simple approach as best as I could, and we've sort of covered it. But I think what we haven't talked about and what is so critical and what winds me up when you get rung up by referring doctors, they just read you a blood gas. The blood gas won't give you a diagnosis on its own, by and large. You've got to have a history and ideally examine the patient. And if you know the patient's septic, or if you know they've taken an overdose and they've got reduced GCS, or they're diabetic, you're halfway there, aren't you? The blood gas just adds to it. And I really can't overemphasize that enough. A blood gas on its own, again, you need to see at least what I put in there, I think. You need to look at the U's and E's, to have a look at renal function, to have a look at the other major cations and anions that we do measure in extracellular fluid. Glucose clearly very important. Bone chemistry is important, and you want to get a lactate as well. Then the first thing is just to work out the primary abnormality. So on the ward round, just say, right, this patient's got an acidemia, the patient's pH is below 7.36. And simply by looking at the pH, the bicarbonate, the CO2 and the base deficit and standard bicarbonate, whichever you prefer, you can work really quite easily from that little table I put up earlier, the primary process, 9 times out of 10, I would suggest. So is the patient acidemic, alkalemic? First start off, what's the primary process? And fundamentally, you're moving towards this simple categorization. Metabolic processes, either acidosis or alkalosis, respiratory processes, acidosis or alkalosis. If it's a metabolic acidosis, classify it as a non-anion gap or anion gap, and have a think about the Osmolal Gap as well. If it's a metabolic alkalosis, not so common in our game, acute care, people do talk about the chloride responsive and chloride unresponsive. That's to say that they'll probably get better if they're chloride responsive with a bag of normal saline. I'll come back to that in a second. And then obviously respiratory acidosis or alkalosis. Then have a think about the compensation mechanism. Work out if it's an acute change. Is there an acute compensation? If it's someone with a chronic respiratory acidosis, is there a chronic element? And if you've got time, have a think about those simple equations we went through. And it's quite interesting to apply them from time to time. If you find the compensation equation leaves you with a gap, that the compensation is incorrect, what you're going to ask yourself, is there a secondary process? So is there two causes of the acidosis, both respiratory and metabolic? And it could lead you to that. So more quantitatively, if you've got someone, let's just pick the metabolic acidosis, if the expected CO2 is significantly higher than according to the equation, you've got to ask yourself, is there something causing a respiratory acidosis on top of it? Metabolic acidosis, if the bicarb is lower than expected, is there respiratory acidosis, if the bicarb is lower than expected, could there be a metabolic acidotic process going on as well? So it's kind of common sense, but just think it through in those simple compartmentalized way, and you'll sort of move towards the right answer. Have a look at the anion gap and the Osmolal gap. Don't forget about those organic substances. Treatment, obviously, early treatment, particularly for methanol, ethylene glycol, can make a big difference. In the presence of a raised anion gap, then you've got your list of causes, measure the serum ketones, think about toxicology. If it's below the threshold for normal anion, then think about the non-anion causes. Just to go back to the chloride responsiveness. So this is just, we don't do this very often, we should do it more, I think, and I guess Ricky does it more. It's just looking at urinary electrolytes, and particularly urinary chloride. So if there is an abnormally low urinary chloride, it might well be there's chloride retention and the patient's hypochloremic, and they're likely to be chloride responsive. Causes of that are often pre-renal causes, gut losses, diuretics, those sorts of things. If it's over 20, they're going to be probably chloride unresponsive. And it's quite rare things, again, Ricky, you throw any light on, but things like primary aldosteronism, Cushing syndrome, where the kidneys are excreting potassium and causing the deficit. Magnesium depletion is something we don't think about very often. Do you measure urinary chloride, Ricky, much?
You put me on the spot here, Gareth. Yeah, occasionally. I wouldn't say much, but yeah, very occasionally. But if I'm honest with you, every time I do, I usually have to sort of remind myself and look it up.
Yeah.
Yeah.
You know, and it gives you an idea of renal function as well, and you know, sodium handling. And it's something we should probably do more, to be honest. So metabolic alkalosis, just think of the chloride and the responsive and the non-chloride. You know, the classic GIT one is the kiddie, isn't it? You know, with vomiting and hypochloremic metabolic alkalosis. And a bit of chloride does them the world of good. So I think the biggest emphasis I want to make is knowing those basic rules. We're using the carbonic acid system, but please don't just look at blood gases. Think about diagnosis and other blood tests, and blood gas is an adjunct to that rather than being the whole thing. I think is absolutely key. I think that's it for me. So anything I've missed or anybody want to go through or look at again?
Chloride responsive. I'm just a bit lost. You're saying that if the patient has urinary chloride of less than 20,
yeah,
they respond if you give some. If it means they'll respond to chloride, giving saline or something like that.
So if the urinary chlorides, that's the anion gap, sorry, wherever. Yeah. So for primary metabolic alkalosis, if you measure the urinary chloride, if it's low, that suggests, this is my simple thinking, the kidneys are holding on to chloride. Yeah. Therefore, that would represent probably a total low body chloride. Yeah. And if the kidneys are underperfused, that you'll have a secondary hyperaldosteronism effect with low renal blood flow. And if you're holding on to chloride, you'll excrete hydrogen ions because you've got to have electroneutrality. Yeah. In which case, if you give chloride, you'll get rid of that alkalosis or that alkalemia.
So you're retaining chloride and losing the bile.
Correct.
Chloride.
Yeah. No, you'd be losing, so you're training chloride, you'd be losing hydrogen ions to maintain neutrality. Ricky, help me. I think that's right.
I think that sounds about right. Yeah. Again, it's metabolic. I was going to say all these things. The most common, certainly I come across, is metabolic acidosis. We do see a bit of alkalosis, but again, it always means I usually have to refresh my memory and look at my notes on my phone to see what I'm doing. But yeah, that would be my understanding. Yeah.
So diuretics can do that, but the classic one is upper GI losses. If you're vomiting a lot of hydrochloric acid up, and you get the classic, you know, in pyloric stenosis in kidneys, the classic hypochloremic metabolic alkalosis, and it's just a case of rehydrating them with chloride, obviously sorting out their pyloric stenosis. And the unresponsive ones have a urinary chloride of greater than 20. And the only examples I could come up with are sort of endocrine causes. And for some, I didn't look into the biochemistry, but for some reason, significant magnesium depletion in isolation can give you a metabolic alkalosis, which is non-chloride responsive. Don't ask me why though.
I quite understand that. I quite understand that.
No, I'll dig into it. There must be a reason. So that was all I had. So I kept it relatively short. I thought we had a couple of papers. We probably could have done a couple of clinical vignettes, but I didn't do any. Any other comments from anybody? Any thoughts?
So as someone who has never really used the kind of compensation calculations, is that still applicable when someone's on like mandatory ventilation? It's like the scenario I have in my head is, someone who's septic with primarily a metabolic acidosis, then intubated and ventilated, and it could be that you've got the ventilator settings not quite right, and then fill the CO2. So how can you apply that to?
So I don't think I hear what you're getting at. I mean, all you've done is use the ventilator as a surrogate lung, but you have control of minute ventilation to some degree. So the rules would still apply, and it may trigger you to realise that your compensation with ventilation isn't adequate. So if you work out the compensatory rules and you find that the change in the bicarbonate resulting in your ventilation is less than predicted, you need to potentially ventilate them a bit more. So I think you can still apply them,
Especially in the DK patient who needs intubation. I found myself using it.
Yeah, absolutely.
To just continue the compensation as you're trying to correct.
Yeah, so I don't think a patient being on a ventilator, I think where it gets more complicated
changes your management in that you'd be encouraged to ventilate them harder, because my normal practice, if someone was super acidemic, I'd just blow them as hard as I could. Do you think that would?
No. So I mean, one of the problems we have when we choose to ventilate people is the control of CO2 on the mechanical ventilator is much less effective than it is with a person breathing spontaneously because of changes in VQ mismatch and diffusion. And this is why I'm open to anyone else's thoughts. I would only intubate a DK as an absolute last resort, where their airway's compromised, when they're comatose, because you lose. There's no way you'll ventilate someone down, particularly if they're hypermetabolic, to a CO2 much below about 3. I made that number up, but 3-ish. I've seen plenty of DKAs with CO2s of 2 or even below when they've got base deficits of 27, pH of 6.8. So it's why we wouldn't. The mechanical ventilation is not as effective as acting as a respiratory compensator as a patient breathing spontaneously. I think where some of this, what I thought you were going to say, some of this acid-base theory probably starts to get a bit more complex is filtered patients, when we're using filtration and citrate and targeting the parameters that we do on renal replacement therapy. That gets a bit more complicated in terms of using traditional acid-base theory. But by and large, I think all of what I've said can apply to the IC patient on multi-organ. It's a perfectly good question on multi-organ failure, would be my view on that. Anyone else have anything to add?
Can I, Gareth, just to add, I think certainly with the metabolic compensation, I think that was all done on kind of awake self-ventilating patients for Winter's formula. So that's not something I would think about when I've got a patient necessarily on a vent. Yeah. When I read the Winter's formula, which is specifically the metabolic acidosis one, the things I was reading, these were done 20, 30 years ago. They're seen as a guide rather than absolute science, and they've not been repeated for a long time. But yeah, so maybe a word of caution with that particular one if you're ventilating somebody. Okay, well, I kept that short and sweet, just an hour. We do have a couple of questions, actually. Sorry, Gareth, to keep you occupied.
Ended early.
What's your feeling about sort of venous blood gases? Because that seems to be, and it certainly seems like over my lifetime, it seems like that's kind of now the most common thing, is that people do a venous blood gas.
Yeah.
Come to you with that, really.
So I've not talked about blood gases. I've just concentrated on acid base, obviously. And in terms of acid base assessment, I think a venous blood gas is reasonable. clearly, if you want to look at partial pressures of gases, I don't think a venous gas is much use.
Yeah.
I think, for us, I think the thing we don't do often enough is both together, arterial and venous, which can often help with looking at CO2 gaps and oxygen uptake, particularly if you can access a central line or in the absence of a PA catheter. I think the quick assessment, because the blood gas machines now give us so much information, glucose, lactate, the electrolytes, the hematinics, I can see why it's done in the absence of an arterial line. And I think in ED now, do they do capillary on adults? Or is it all venous? Yeah, okay. So I think in answer to your question, Ricky, as an assessment of oxygenation, carbon dioxide, no. I guess as a quick assessment of acid base and looking at some of the parameters that feed into that, in the absence of an art line or a difficult arterial stab, I think it's a reasonable thing to do. What's your view?
No, similar really. I think we just get, certainly my experience, we get referred a lot of patients in renal, or we get sort of junior doctors coming to us with a blood gas or a venous gas, sort of saying the pH is low, and then you look at it and actually the sort of pH, yes, whilst it's low, the base deficit, the bicarb's pretty relatively normal, and I think that kind of a lot of people mistake that for always being a metabolic acidosis and not. They don't always think about the CO2, the respiratory component. Really.
I mean, don't get me wrong, the gold standard, I think, and what we're used to interpreting is arterial, and what I would want to see ideally. I guess it's only in the absence of maybe access for that. It might give you some information, but yeah, I think arterial is always going to be the gold standard, isn't it?
Yeah, I think so. But then I can understand why people do it, because I think it is easier. I think it's just sort of bearing in mind the limitations to it.
Absolutely.
Vass has got a question. Do you ever adjust the anion gap for albumin? And he's got
anion gap for what? Sorry.
For a low albumin.
Yeah, you're right. You should, and I don't. I saw a few equations that would allow for that, and albumin plays a big part. Absolutely, and. I suspect, some of the patients we see with their albumins are below 20, we should be doing that, I think, Vass. It's a very good point. But it's not something I do off the top of my head, I've got to be honest. Do you do that, Vass? Is that something you do?
He's put it in the chat that, that is something that he...
No, it's a very, very valid point and alludes a little bit to some of the stuff in the Stewart concepts. So, as a sort of generally alluded to, major changes in bulimic status, major changes in other electrolytes, plasma proteins, really starts to make our simple acid-base approach to bedside a bit tenuous. Adjustments, relatively easy adjustments like that, I think are a very good idea, absolutely.
I suppose any other questions from anyone else, really? I think that's about it. Gareth, that's been brilliant. That's been sort of really good. I think
it wasn't too simple. I just wanted to try and keep it relatively on the ground. I should have stuck a couple of clinical things at the end, but I wasn't sure what my time frame was, so maybe next time.
No, Gareth, it's been brilliant, actually. My view, I think blood gases are really important. I think they can tell you a lot about what's going on and a lot about what you need to do to try and fix what's going on.
Yeah, I remember Dale Garner at Nottingham saying years ago, and I agree with him, he said, there's something about being an anaesthetist and an intensivist or just an intensivist where you just feel you should know more about blood gases than anyone else in the hospital. Yeah. It's just one of those things you feel you've got to know about and not be caught out by, particularly a physician.
Yeah, so certainly the anion gap stuff, I find that more and more useful actually, and it's I think it's good.
Brilliant. Well, thanks everybody.
Cool. Thank you everyone. So there's no journal club today, I'm afraid, so a bit of an early finish, but I hope that's been useful. And I think we will probably send around the feedback form, the feedback QR code at a later date for that.
I don't know what you do with the presentations. It's not worth very much, but do you want me to send it to you so you can distribute it, or I don't know?
Yeah, by all means, yeah, send it to me. So all these are usually uploaded onto YouTube, so people can sort of watch it.
I'll send it to you, Ricky, so you can do that.
Yeah, cool.
Cheers.
Cool. Okay. Well, thank you very much for attending, everybody, and we'll see you next time.
Lovely weekend, everybody. Bye.
Bye.